The following podcast is part of a certified educational activity featuring expert insights and patient caregiver perspectives on the management of spinal muscular atrophy. Access the entire activity and complete the post-test at peerview.com/HNM. Downloadable slides and practice aids are also available.
Hello, my name is Dr. Perry Shea, and I'm from the University of California, Los Angeles. Welcome to this educational activity entitled Ensuring Optimal Management Throughout the Clinical Spectrum of Spinal Muscular Atrophy. This activity will cover SMA presentation and progression, the importance of early SMA diagnosis, approved treatments and symptomatic care for SMA, and support for patients with SMA and their caregivers. So spinal muscular atrophy is a progressive neuromuscular disorder that results in the progressive degeneration of spinal motor neurons. Now, spinal motor neurons are the neurons that innervate the muscles, and through this progressive degeneration, the muscles become weaker and atrophy. And so this is what we see in these patients. They become progressively weaker, resulting in the symptoms that they have. It's an autosomal recessive disorder, and it affects approximately 1 in 6,000 to 1 in 11,000 live births in the United States. The carrier frequency is estimated to be approximately 1 in 40 to 1 in 60. SMA is really caused by a deficiency of the SMN protein. So these patients have less SMN protein than they need to have to be able to maintain survival of their motor neurons. Now, this SMN protein is primarily encoded by the SMN1 gene, which is shown here. And what's shown here is there's also a second gene, which is very similar to SMN1, called SMN2. Both of these are located on the long arm of chromosome 5. Now, the SMN1 and SMN2 genes are similar enough that they actually encode exactly the same protein. The only difference is the SMN2 gene splices a little differently most of the time. And that's what this graph here is showing, that most of the time it splices and excludes exon 7, resulting in a protein which is non-functional and is rapidly degraded. But sometimes it can actually splice in a way which is similar to SMN1, including exon 7, which results in a functional protein. The role of SMN2 is probably of no significance in a person who does not have SMA. However, in a patient who has SMA, the SMN1 gene is either missing or mutated. And as a result, the only SMN protein that an SMA patient would have is being synthesized from the SMN2 gene. If the patient has additional copies of SMN2, then that patient is more likely to have a milder form of SMA than a patient who has less copies of SMN2. Now, most patients who have SMA have a homozygous deletion of SMN1, meaning that both genes are actually deleted. However, 5% of patients, which is a small minority, actually have a traditional point mutation combined with a deletion, and this is known as a compound heterozygous mutations. And this second mutation, which is a point mutation, may occur within exon 7, or it could possibly occur in one of the other exons. It would be easier to establish the mutation as causative if it was occurring within exon 7, and it would take a little more detective work to be able to establish the diagnosis if it was outside of exon 7. The diagnostic algorithm for establishing SMA is shown here. And typically the confirmatory testing would be to look at the number of copies of SMN1. Now, if both of them are deleted, then there are 0 copies of SMN1, and this would confirm that the patient has SMA. If the patient has 1 copy, the second copy being deleted, then the patient could still have SMA, and if it's clinically appropriate, additional testing through sequencing of the SMN1 gene could look for point mutations, and that would be in 5% of patients with SMA. If the patient has 2 copies of SMN1, they're very unlikely to have SMA. Now, if the diagnosis of SMA is established, we usually look at the SMN2 copy number because this is somewhat predictive of the severity of SMA. And patients who have more copies of SMN2 are likely to be milder. And this is how we generally categorize patients with SMA, the most severe patients being type 1 and the mildest patients being type 3. The type 1 patients are the infantile patients. They usually present within the first few months of life. And typically they're patients who have 2 copies of SMN2. And we define these patients as patients who never attain the ability to sit. If they do attain the ability to sit, but do not ever stand or walk, then we call them type 2 patients. And they may present a little bit later, after 6 months of age. And these patients typically have 3 copies of SMN2. Now, the mildest patients are the patients who do attain the ability to stand and walk. We call them type 3 patients. They may present even later in life, after perhaps 18 months. And these patients will have more copies, typically 3 or 4 copies of SMN2. And this graph here is just to illustrate, patients who have SMA type 1, 2, and 3, and how they may compare to a normal individual. And what you can see here is that type 1 patients are the most severe, type 2 and type 3 are a little bit milder. And what happens is there's oftentimes a period of relative rapid degeneration, and then there's a plateau period after some time. Now, we've gotten better at taking care of SMA patients through time. And this is a study that illustrates this difference. So patients who were born in the 80s and early 90s, for instance, had this survival curve that's shown here. And that's compared to patients that were born 1995 through 2006 in this study. And what you can see is that there's a significant difference in the survival. Patients born 1995 through 2006 definitely were surviving at a much higher rate. But the main difference between these 2 groups is the standard of care and the interventions that were used later on in the period after 1995. There's a lot more ventilation that's being used. There are cough assist devices, also known as mechanical insufflation exsufflation devices, which helps to clear the airways. And gastrostomy tubes for feeding were more commonly used. And it's important to point out that SMA patients oftentimes experience this diagnostic delay. And in a systematic review of the literature, you can see here that type 1 SMA patients, on average, have a diagnostic delay of 3.6 months after symptom onset. Type 2, longer, with 14.3 months, and type 3 patients up to 43.6 months. And in the era of having pharmacotherapies which are effective at treating patients, better outcomes would be seen if the interventions are given earlier, which means that we need to be better at diagnosing patients earlier. Of course, it is helpful to have newborn screening, and SMA was added to the recommended uniform screening panel in July of 2018. More than 31 states have implemented this uniform newborn screening for SMA at this time, and that covers about 65% of newborn babies in the United States. It's also important to point out that newborn screening only looks for homozygous deletions of SMN1, and that only covers 95% of patients with SMA. So in other words, newborn screening would miss the 5% of patients who have compound heterozygous mutations. And so these patients would still need to be diagnosed in the traditional manner. So the key takeaways of this first section are SMA is a progressive autosomal recessive genetic disorder due to a loss of the SMN1 function. SMA severity varies and is influenced by the number of SMN2 gene copies. Interventions that improve outcomes are available, and we'll be discussing them shortly. And newborn screening facilitates early intervention but may miss some individuals with SMA. Okay, so in this next section, I'm going to be talking about approved therapies, treatments, pharmacotherapies for spinal muscular atrophy. and looking at the evidence across the clinical spectrum. So nusinersen, the first one I'll talk about, works by modulating the splicing of the SMN2 gene. So as I discussed earlier, the SMN2 gene can make a functional SMN protein, but it does so at a lower efficiency. And the reason why it does so at a lower efficiency is because it's not spliced correctly most of the time. However, if we are able to modulate splicing so that the splicing favors a more full-length SMN2 messenger RNA, then that would restore the amount of SMN protein that the patient is making. And this is just a figure to show you this. Over here on the left, nusinersen is this antisense oligonucleotide that binds to the intron that's downstream of exon 7, and that appears to be a critical sequence which affects the degree to which exon 7 is included in the final transcript. And by binding that site, exon 7 is included more, and therefore SMN protein expression is increased, thereby addressing the underlying deficiency that patients with SMA have. Over here on the right is onasemnogene abeparvovec, and this figure here is to illustrate that there is a viral capsid, which is an AAV9, adeno-associated virus 9 capsid, that's being used as a vehicle to deliver the transgene, which is SMN1, into patients with SMA, thereby replacing the SMN1 that's missing in patients with SMA. And in the middle is risdiplam, and this is just to illustrate that risdiplam works by binding to certain splicing proteins which have a similar effect to what nusinersen does, which is to increase the degree to which exon 7 is included in the final transcript, thereby restoring the degree of SMN protein expression. So what I'm going to do now in the rest of the section is to go through the data, particularly for nusinersen and onasemnogene abeparvovec, going through the type 1 data and then the data in pre-symptomatic patients, so the patients who are very young, just newborns essentially, and then as well as looking at type 2 patients, somewhat older but milder. So the first study I'll discuss is in DEER. This is the nusinersen study in type 1 patients. So these are infantile SMA patients. They have 2 copies of SMN2, so they're predicted to be type 1 patients. And these patients were recruited within the first few months of life, and they had to be dosed under 7 months of age. And they could not have any problems with oxygen saturation. They're randomized 2 to 1. There were 121 patients that were recruited across this international study. And so 2/3 of them received nusinersen, and 1/3 of these patients received a sham injection. So this is a way of doing a blinded study. It was deemed unethical to inject placebo, so the investigators either did an intrathecal injection of nusinersen or pretended to do an intrathecal injection of nusinersen. The primary endpoint was, there were 2 of them. There was the motor milestone response. So motor milestones are what you typically look for in infants that are developing, like head control, sitting, standing, crawling, those types of things. And the scale that's actually used is the Hammersmith Infant Neurological Examination. There's also a survival endpoint, and so what's defined here is the event-free survival, and that's the ability to survive without the use of permanent assisted ventilation. So these were both primary endpoints. And what you can see here on this slide is when you look at the motor milestones, that the patients who received nusinersen clearly gained motor milestones that the patients who were on sham did not. And this divergence was quite clear after just a few months, as you can see. If you look at survival, once again, event-free survival is this ability to live, survive without the use of assisted ventilation or permanent assisted ventilation. And you can see that the patients who were treated nusinersen clearly were able to sustain this type of survival much better than the patients who were in the sham-treated control group. You can also look at overall survival, just looking at the fraction of patients who survived and were able to live, and you can see that the survival was also better in the nusinersen arm than in the sham-treated control group. Now I'm going to shift to the type 1 patients in the gene therapy study. And there are a number of gene therapy studies, but I'll focus on the START study, which was the first study that was ever done on this product. And so this was a small study. There were 15 patients in this study. They all had type 1 SMA. They all had 2 copies of SMN2, which of course predicts the patient to be a type 1 SMA. And 3 of the patients were in a lower dose cohort, and then additional 12 patients were in the second cohort, which was a higher dose. This actually ended up being the therapeutic dose, which we now use for this product. And so the original intention of the study was to look for safety. But of course, it's interesting to look at the efficacy outcomes that are quite apparent in this study. If you look at event-free survival, 100% were surviving, 92% had head control, 75% were able to roll over, assisting unassisted, 92%, and 50% required no nutritional support. And these are very significant findings compared to the dismal findings that we typically see in the natural history. And we show here this historical cohort just for comparison. If you look at motor skills as measured by the CHOP INTEND score, over here on the left shows the patients in cohort 2, the final therapeutic dose. And what you can see here is there was a pretty significant rapid response based on this motor skill scale, the CHOP INTEND score, among the patients who were enrolled in the study. And on the x-axis is age, so some patients were dosed a little younger and others were dosed a little bit older, but there was an uptrend in nearly all the patients except for the one who was dosed much later at about 8 months. If you compare what we would typically see with patients with type 1 SMA, you can look over here on the right, the NeuroNext study, which is one of the natural history studies that's published on type 1 SMA, and you can see here in the red that the curve of the CHOP INTEND scores is definitely heading downwards and is very different from what we're seeing over in the patients who were in the START study. Going back to the nusinersen study, the ENDEAR study, it's interesting also just to see if disease duration had an impact on the response that the patients exhibited. So in other words, if the patients had exhibited symptoms longer, did they do as well as the patients who had only had the disease for a shorter duration? And so one of the analyses that's been provided is to look at the median disease duration, which was 13.1 weeks, and basically divide the study in half. So look at the patients who had had the SMA longer or had had symptoms longer compared to the patients who had symptoms for a shorter period of time. So if you look over here on the left, looking at the patients who had had shorter disease duration, less than 13.1 weeks, you can see that the nusinersen-treated patients had a larger difference compared to the control group. And that difference was more significant than what we were seeing over on the right, which is among the patients who had a longer disease duration, the patients who had disease duration greater than 13.1 weeks. And that really speaks to the fact that early intervention really is more likely to have a significant benefit in this agent than later intervention. If you look at the gene therapy study, this is probably the closest analysis you can have that draws the same type of information. Over here on the left, you can look at the age as well as their CHOP INTEND score at the time that they were dosed. And I think what you can appreciate is that each of these curves is an individual patient. The patients who started off higher on the y-axis, so higher up on the graph, tended to do better than the patients who started off lower. And age has some bearing as well. You can see the patient who was dosed a bit later at about 8 months also did the least well. If you look over at the motor milestones, which is over here on the right, you can see that the patients who had a higher CHOP INTEND score, so that's the y-axis, tended to achieve more milestones than the patients who started off with lower CHOP INTEND scores. And age had some influence as well. Now I'm going to shift to pre-symptomatic patients. So looking at the nusinersen study in pre-symptomatic patients, this has the nickname NURTURE. And so this is an open label study. There were no controls in this study. And 25 patients were recruited into the study. 15 of them had 2 copies of SMN2, so predicted to be a type 1 patient. And 10 had 3 copies, so they're predicted to be a type 2 patient. And this is data that is as of the February 2020 cutoff. And at the time of this cutoff, the median age of these patients was 3.8 years. All were alive and none required tracheostomy or permanent ventilation. I first show here the CHOP-INTEND data looking at these 2 different cohorts. So the 2 copies that are predicted to be type 1 or the 3 copies that are predicted to be type 2. And what you can see is that there's a rapid response among these patients who were treated with nusinersen. And the curves are more or less similar. There may be some slight differences, but they were all improving and doing well. And many of them reached a score that was very close to the maximum score on the CHOP-INTEND. And the curve on the bottom here you can see is the natural history of patients who have type 1 SMA. And you can see that there's definitely a significant difference between these 2 treated groups compared to what type 1 SMA patients would do. I think it's also interesting to look at motor milestones because then you can look at more advanced skills. And what's shown here are some of the motor milestones, including head control, sitting without support, walking with assistance, and walking alone. If you look at the patients who were predicted to be type 1, you can see that 100% achieved head control, 100% achieved sitting without support, 93% were walking with assistance, and 80% were walking alone at the time of this data cut. If you look at the patients who had 3 copies, so predicted to be type 2 patients, these were the milestones they achieved: 100% head control, 100% sitting without support, 100% walking with assistance, and 100% walking alone. So really doing quite well in that cohort. Now I'm shifting over to the pre-symptomatic patients who were treated with the gene therapy product, onasemnogene abeparvovec. And so this study goes by the nickname SPRINT. And this is data as of the December 2019 data cut. And these patients were dosed with onasemnogene abeparvovec at 1.1 e to the 14th. This is actually the same dose as the dose that was reported in the START study, but they had to redefine it. So this is actually not a dose difference, but this is the way it's reported, and I just want to make you aware that this is exactly the same dose as the START study. 14 of them enrolled had 2 copies of SMN2 predicted to be type 1, and 15 had 3 copies that were predicted to be type 2. And these were the assessments. It's appropriate to use different assessments for these 2 cohorts because the type 1 patients, the patients who are predicted to be type 1 patients, perhaps you want to focus more on sitting, and then the ones who are predicted to be type 2, you'd like to see if they are able to stand. And so that's exactly what was done. The primary outcome measure that was defined for the type 1 2-copy patients was the independent sitting for greater than 30 seconds. And among the type 2 or 3 copies of SMN2, it was independent standing for greater than 3 seconds at 24 months of age. And there are some other secondary outcomes as well as exploratory outcomes that are listed here. So this is an ongoing study, so we really don't have the final results of this, and the final readout of this study will likely continue to change and will likely be significantly different from what we see at this point. But what can be appreciated is the number of patients who have already attained some of these milestones. So you can see here, all patients are alive and free of ventilatory support. There's no feeding support required. And among the patients who had 2 copies, 8 have already attained the ability to sit independently for greater than 30 seconds. Some were even walking independently, and I'm sure that number will increase as the study continues. And here are some of the CHOP-INTEND scores. Among the patients who have 3 copies of SMN2, 4 have already attained the ability to stand independently, which is the primary outcome measure for this cohort. And again, this is data that's still accumulating as the study continues, so I'm sure there will be more in the final analysis. And 3 are walking independently at the time of this analysis. Now I'm going to shift gears to the type 2 patients. And so the type 2 study for nusinersen is known as CHERISH. And this is also a double-blind sham-controlled study. 126 patients with SMA were enrolled in the study. They were randomized in a ratio of 2/3 to 1/3 to either receive nusinersen or the sham injection, so very similar to what was seen in the India study. Patients were ages 2 through 12, and they had to be patients who never attained the ability to walk independently. The primary endpoint that was defined was the change in the Hammersmith Motor Scale Expanded at 15 months of exposure to the treatment. And this is to show you this efficacy data, the Hammersmith Functional Motor Scale Expanded, showing that there's a significant divergence in the treated versus the sham-treated group. And you can see that the patients who were treated with nusinersen on average gained 3.9 points compared to patients who were treated with sham, who on average lost 1 point, leading to a difference of 4.9 points comparing these two cohorts. So these are patients who don't stand or walk, at least by inclusion-exclusion criteria. So you can't really assess their ability to walk per se, but it's helpful to look at how well they can use their upper extremities. And so this was done with this revised upper limb module, which is a scale to look at how well these patients can use their hands and their arms. And you can see that there's also a significant divergence in the treated versus the untreated group. There are some additional outcomes which are listed here in the final analysis. 57% of patients who were treated with nusinersen attained at least 3 points on this Hammersmith score, and that's compared to 26% in the sham-treated control patients. The overall incidence of adverse events was similar in these two groups. And I just list here some additional studies among older patients. This is just to show you that there does seem to be some evidence that even patients with more advanced disease, so older type 1 patients, or even older type 2 and type 3 patients can have some improvements. And so what's shown here is some of the data showing gains in the CHOP-INTEND among older type 1 patients as well as adults, in this case defined as greater than 16 years of age who had type 2 or type 3, showing gains on the Hammersmith score. And finally, there is a study which is not yet completed. This is looking at type 2 patients and treating them with intrathecal gene therapy. So the gene therapy I've been talking about so far is intravenous, but this is intrathecal, a new route of delivery. And all these patients were type 2 patients who had 3 copies of SMN2. So this is a study that's been on pause, and there will likely be additional data once the study resumes. But on average, there was an increase of 5.9 points in the Hammersmith with a mean follow-up of 9.3 months. So far I've talked about nusinersen and onasemnogene abeparvovec. I've not talked about risdiplam very much because some of this data is still emerging, and this is just to give you a high-level overview of some of the data that has been released and is in the public. There's the SUNFISH study, which is a study looking at risdiplam in patients, type 2 and type 3 patients, ages 2 through 25. And you can see that there's also a FIREFISH study, which looks at type 1 patients under 7 months of age. And there's some favorable data looking at survival as well as some efficacy measures on motor function that are just listed here on the right. So the key takeaways in this section: data demonstrate the efficacy of these treatments at different times in the disease progression, spanning the pre-symptomatic as well as early symptomatic. And more recently, we've seen some late symptomatic studies that have shown some efficacy. This information can help physicians in guiding treatments across the clinical spectrum of individuals who have SMA. So in this last section, we would like to cover symptomatic care and support for SMA, and really going through some of the recommendations, the key recommendations, as well as getting a patient's perspective. And today we're going to be having the perspective of a mother with 2 children, 2 boys who have spinal muscular atrophy. So some of you may be aware that there has been a recommended treatment algorithm for spinal muscular atrophy. This was developed and published in 2018, around the time when spinal muscular atrophy was added to the recommended uniform screening panel. And the idea behind that is to try to identify patients who really should be treated so that there's less confusion. Obviously, the patients who are identified through a newborn screening that to be positive for SMA, and those patients who are predicted to have severe forms of SMA, it's an easy decision to start a disease-modifying treatment. However, it became a little bit less clear exactly what patients should be treated on the milder end of the spectrum. And at the time of this publication, it was recommended that patients who are more on the severe end of the spectrum, who are predicted to have severe disease through the SMN2 copy number, were recommended for treatment. So patients with 1, 2, and 3 copies of SMN were recommended to undergo treatment. Whereas patients with 4 copies of SMN2, it was not as clear. And with newborn screening, it really highlights how the population of SMA patients is going to start shifting. So what you can see in this slide is that currently we're looking at a fairly significant number of patients who have already been diagnosed with SMA. So the patients over here on the right, or perhaps the patients who are being newly diagnosed and have symptoms. So this would be considered the prevalent population of patients. Whereas the patients who are pre-symptomatic, newly born, identified through a newborn screen, these would be patients that you might call the incident population. And so looking at treatment, when these patients are starting treatment, initiating treatment, you'll see that right now the current situation is that most patients who are initiating treatment are in the prevalent population, and a small fraction of patients are in the incident population. I think with time, you can appreciate that we will be identifying more and more pre-symptomatic patients, and they will have undergone some type of treatment. And so the population of pre-symptomatic patients is going to start growing. And then you're going to also see that the population of prevalent patients prevalent patients when they were treated is going to start diminishing as they age out. But nonetheless, I think it's important to address the fact that many of these patients, even perhaps some of the patients who are treated pre-symptomatically, will have ongoing supportive needs. And so we will be talking about that. Now you're going to hear from Mrs. Kobayashi, who has 2 children with spinal muscular atrophy, and she's going to share some experiences that she has with her children.
So between my sons, there's 4 years had passed. For my first son, basically we were told, your son has SMA type 2. There's not much out there. There either weren't any treatments for his age or there weren't any treatments at all, that there is no cure. And we basically were told, go home, keep him healthy, and give him exercises. And that was such a vague answer for us. Being a first-time mom, what does that mean? Keep him healthy. What does that mean to give him exercises? And I know that was about 9 years ago and a lot has changed since then, but that's all that I was given. And, that was around the time that Facebook had started. There weren't very many support groups. I literally found my first mom, friend, family of SMA through a YouTube video. And even that video was posted a long time ago. So I didn't even know if, where this family was, but resources were so limited 9 years ago. Then we had our daughter, and then we had our son, and then with our son being diagnosed about 4 years later, there were so many things available for us. And the Facebook community had kind of picked up, and then it was easier to communicate that way. There was a Cure SMA, the group reached out to us. But also at the time of my son's birth, waiting the 3 weeks was a very long 3 weeks. But at the same call, during the same call that we got the diagnosis, We also were told that there was a trial available, and if we wanted our son to be a part of it. And so many things happened during that call, like a rush of emotions that, here's your son's diagnosis, but there's something available for you. So that diagnosis was very, very different than my older son's diagnosis of the time that was that it was presented to us. From here's your diagnosis, there's nothing we can do, and there's nothing available right now, to here's your diagnosis, but there's great things happening. Do you want to be a part of it? And so to us, it was kind of a no-brainer. Well, yeah, we're going to do that for our son because there's something available for him. And we jumped at the chance.
Thank you very much, Mrs. Kobayashi, for sharing that with us. I'd like to shift now to talking about monitoring and managing some of the symptoms that patients with spinal muscular atrophy would have. And really, it takes a multidisciplinary approach. And as you can see from this figure here, there are a number of different disciplines that may be contributing to the care of an SMA patient. And which disciplines are contributing really depends on the patient himself or herself. What symptoms, what severity they may have. There may be pulmonary and orthopedic interventions. There may be significant nutritional interventions. These are some of the more common interventions that we see in patients with more severe disease. Patients who have milder forms of SMA may have mostly orthopedic needs. And so there really has to be a coordination among all these different disciplines, and making sure that they're talking to one another, making sure that there's a reasonable understanding of the disease of spinal muscular atrophy among all the providers that are involved. I'd like to invite Mrs. Kobayashi to come and provide some of her experiences.
For my oldest son, who is 9 years old, he started treatment at 3.5. So when he started treatment, he was already weak. He started using his little wheelchair at around 2 years old. So he had already presented signs of weakness. That included a very hands-on experience with him. From waking up in the morning, he needed 100% help getting in and out of bed, being put into his wheelchair. Well, before that, there's bathrooming, needing help to get into his wheelchair. At the time, he was still pretty weak, so his wheelchair he sat in, but we still pushed him around in it. And he was small enough to be easily pushed around. He was only 2 years old at the time, and he was kind of getting the hang of using a wheelchair. So he needed more help to do things, get around. His arms were very weak, so reaching for things that fell on the floor, we would pick up for him. He was very... he needed to have a lot of help. At the time when we started, at the time of diagnosis, we weren't really given much information on how to care for a child with SMA, except for give him exercises, which we didn't know at the time, but meant, physical therapy. So at 2.5, 3 years old, we started physical therapy. We were going about twice a week. And I was pregnant at the time. So we would be driving along to PT with my 2.5-year-old and my newborn at the time, twice a week. He would have his regular doctor's appointments periodically, his health, wellness visits that were once, twice a year. But we were more active with going to physical therapy twice a week. We were also being seen at Children's Hospital every 6 months for the MDA clinic, where we were able to see all of his doctors at one visit rather than us going to multiple visits throughout the year for I think it was 6 months. Every 6 months we would go to our MDA clinic visits, but with him at that young age, we tried everything to keep him healthy, as in, not get sick, colds or anything. And that was pretty much our routine as far as doctor visits. With my second son, who started treatment at 3 weeks old, who showed no symptoms of weakness, he lives a typical life. He walks, runs, jumps, he tries to fly, he thinks he's a superhero, but he does not use a wheelchair. He does not go to the 6-month MDA clinic visits at our children's hospital because he doesn't need to. He's very strong. So care between the two boys was very, very different, is very, very different. One that needs a little bit more help, well, a lot more help, and one that doesn't. My youngest does not go to physical therapy. He does not need physical therapy. He does not wear any orthotics, braces, or any sort. So he has little to no doctor visits. And my oldest does. So doctor visits are very different between the two boys.
Thank you very much for that. Now, there are also rehab recommendations, and I'd like to just characterize rehab in general as the ability to give patient more function or mobility. So among non-sitters, we're talking about optimizing function to improve comfort and minimize deformities. Among patients who can sit but cannot walk, so the sitters, you really want to focus on preventing contractures, monitoring and addressing scoliosis, promoting mobility function, particularly of the upper extremity, but also with transferring. And with ambulant patients, they are ambulating and they want to stay ambulating, so you want to promote mobility, make sure there's maintenance of joint range of function, range of motion, as well as balance and endurance. And so what I'd like to do now is go through some of the specific highlights of how these different disciplines might address some of the needs of spinal muscular atrophy patients. So with regard to orthopedic management, many of these patients develop spine deformity, and that might require some bracing. A surgical intervention is often necessary if there is a spinal deformity, but typically we'd like to delay that until at least 4 years of age. There's hip instability, particularly among patients who do not walk or patients who had delayed walking. And so that may require some surgical intervention. Contractures and fractures also require intervention. Now, there are also nutritional needs, and that also depends on the severity of the patient. Certainly patients who are on the more severe end of the spectrum may have swallowing dysfunction and may not be able to consume food and require a feeding tube. And so that needs to be monitored. We would also want to make sure that patients are appropriately nourished, and many non-sitters actually are undernourished, and undernourishment leads to muscle breakdown in a lot of cases. Among the patients on the milder end of the spectrum, because of inactivity, these patients oftentimes tend to be overnourished, and so we have to watch out for that because being overweight is going to impact their mobility as well. And just decreased mobility is likely to result in gastrointestinal dysmotility, and so you may see issues with reflux and constipation, and that may require interventions, including bowel regimens and other types of interventions. Now, with regard to respiratory interventions, we would want to assess these patients depending on the severity of their respiratory impairment. So patients who are non-sitters tend to require more interventions and may require more assessments. They may need pulse oximetry, sleep studies, looking at pneumograms, a number of different assessments. Sitters who are a little bit milder may just need to have cough function assessed, have spirometry. Standers and walkers, they may just have some obstructive sleep apnea or some mild hypoventilation that can be picked up on sleep studies. And so we really want to take a proactive approach rather than a reactive approach and introduce interventions early to maintain function. So I'd like to ask Ms. Kobayashi to provide some of her experiences.
My oldest son is very intelligent, very smart, very vocal, very social, and loves being at school, going to school every day. He has lots of friends, and that is made possible through a full-time aide. My youngest son now, who's 4 years old and is starting kindergarten this year, will be going into mainstream class with no wheelchair, with no full-time aide, with no restrictions of the playground. who is able to participate in every physical activity at school and literally lives a life of a typical child. I had his kindergarten teacher ask me if there were any physical concerns that she should be notified about. And she happens to be a good friend of mine, and I happened to give her a brief summary of my son's diagnosis, that he technically has a diagnosis of it, of SMA type 2, but he lives a typical life. So there are no concerns, physical concerns, that she would have for my youngest son. So both kids, SMA type 2, they both go to school, but go to school very differently. One thing also I wanted to share is that I work full-time, so I'm able to take the kids to school in the morning, but then they come home on the school bus, which is exciting for them, and they're all together, but I'm not able to pick them up from school, and it's so nice that they are able to ride the bus home together.
Thank you, Mrs. Kobayashi, for sharing that with us. Finally, I'd like to discuss some of the impact that all these interventions and management really have. Caregivers are very much involved in the care of the SMA patients. This is going to increase expenses, and these are expenses that sometimes are not directly reimbursable by insurance payers. There could be reduced income and lost career opportunities. And sometimes just getting equipment or even getting care requires additional time and stress that the patient's family members might have to endure. Of course, the healthcare team can provide some help, and social work is oftentimes very helpful. Disease-modifying agents that have been used more recently have really provided some benefit that have alleviated some of the burdens that some of the caregivers are experiencing. Finally, I'd like to go through some COVID recommendations that are more specific to spinal muscular atrophy. So the potential impact of COVID-19 on spinal muscular atrophy care really can result in disruption of clinical care just because of the impact it has on the healthcare system. Individuals with SMA may be at increased risk for serious illness as well. In fact, we should really consider patients with SMA to be some of the patients with serious risk due to COVID-19. SMA treatments, planned and non-emergent, should not be perceived as elective. Patients who have interrupted treatment should really be reintroduced according to prescribing information. And insurance providers may have requirements for physical therapy assessments, and those things really should be relaxed just given the current COVID environment. Continued urgent evaluation and treatment of infants with spinal muscular atrophy through newborn screening is essential. So in summary, there have been new treatments that have the potential to change the natural history of SMA patients and improve care and burdens for caregivers. And ongoing monitoring and management remain essential to the care of SMA patients. Thank you for participating in today's activity, and I hope you found this information useful.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/HNM. This activity is supported by an educational grant from Biogen. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.